Okay, we're on to chapter 11, and we're going to cover joint connective tissue and bone disorders. So the first thing that we're going to talk about is arthritis and arthrosis. Arthritis is inflammation of a joint, and the two most common types we're going to see are osteo and rheumatoid arthritis. And so as we go on, we'll talk a little bit about both and how you can tell the two apart. Arthrosis is going to be limitation of a joint without any associated inflammation. As with arthritis, you'll see inflammation of the joint. So signs and symptoms of arthritis are going to be impaired mobility. Range of motion is going to be limited in a capsular pattern. And as we get into each one of the different joints, I'll go over what the capsular patterns are for those joints. What a capsular pattern is just a predictable sort of pattern in which we'll lose motion. So if there's ever a problem with a joint capsule or within the capsule, we expect joint motion to be limited in a certain order. And so again, as we get to each joint, I'll talk about what those are. With arthritis, we expect to have firm end feels at the end of range of motion. So we expect a limitation in range of motion, so it's not going to be full range of motion, and when we get close to the end there, we're going to start to feel firmness that resists full range of motion. Joint play is going to be painful, and there may be some effusion or swelling at the joint or inflammation at the joint as well. We'll also eventually see some impaired muscle performance or weakness of the surrounding muscle groups. Again, this is usually due to disuse because they hurt. They don't want to use that body part as much anymore, or some reflex inhibition as well. But again, that's going to mean that there is going to be less support available for that joint. Also, now because there's this potential asymmetry in muscle pull, that can lead to some joint deformation as well. So it is not uncommon with arthritis to see some changes in the joints as well. If the arthritis is affecting the lower extremities, balance can start to be affected, and again, whether it is upper or lower extremities, we'll start to see some activity limitations in the patients as well. All right, so we're going to talk about rheumatoid arthritis first, and then we'll get into osteoarthritis after that. So with rheumatoid arthritis, this is an autoimmune, chronic, inflammatory, systemic disease. There is no known etiology, so we don't know why some people develop RA and others do not. One typical symptom or characteristic of RA is periods of active disease and remission. So I'm not sure if you guys have covered this in disease or pathophysiology yet, but that is one thing we do tend to see a lot with RA. They'll go through periods of sort of flare-ups and then periods of remission. Progression is also going to range, how quickly someone progresses, how many joints this progresses to, and the severity of the disease can also vary a lot from person to person. There is a chart in your book on page 337, and it goes into some of the diagnostic criteria. Typically for rheumatoid arthritis, most patients need to have 4 of the 7 diagnostic criteria, some of which includes symptoms that are present for longer than 6 weeks, morning stiffness lasting longer than an hour, and then it goes on from there. So again, usually once a person exhibits 4 of those, at least 4 of the 7 characteristics, that is one of the tools that doctors can use to diagnose them with RA. So some of the characteristics, again, it's usually symmetric. Osteoarthritis is often not. It's usually more on one side versus the other, but RA tends to be more symmetrical. There is erosive synovitis. So again, RA, because of the autoimmune disorder, it does attack the synovium of the joint, and it becomes flared up and painful. Again, there are periods of flare and remission, and again, it attacks the synovial membrane and the subchondral marrow spaces as well. So it gets down into the bones itself. Granulation tissue can form, and that's what starts to eat away at the articular cartilage. So when that starts to happen, the person is also going to present with signs and symptoms very similar to osteoarthritis. Adhesions may form. We tend to see fibrosis form a little bit more often with rheumatoid arthritis. Ossific ankylosis, that's when the joints kind of start to fuse together on their own, and we may see some subluxation of joints, which again, remember, was a partial dislocation. We do tend to see tenosynovitis, again, more commonly with rheumatoid arthritis, and that's going to be the inflammation of a tendon sheath, which may actually cause a potential rupture of that tendon. The tendon can start to fray because of that inflammation and the way that it wears down that synovial sheath, which does lead to increased instances of tendon ruptures. There may also be some changes outside of the joint capsule as well. So we might see formation of rheumatoid nodules, atrophy and fibrosis of surrounding musculature, and then weakness, fatigue, and there can be some systemic issues that go along with rheumatoid arthritis as well, because it is more of an autoimmune disorder. There is often a decline in functional level, especially when patients are having flare-ups of the disease process, but again, the degree of involvement is going to vary. So you can see some patients with milder forms or cases of rheumatoid arthritis, and then moving all the way up to very severe involved cases. Typically, the loss of joint function is irreversible, so surgery will often be required in order to improve function. So again, similar to osteoarthritis at that point. When a person is demonstrating active RA or symptoms of RA during a flare-up, they'll have joint effusion or inflammation that's most prominent in the morning. It hurts to move. There can also be increased skin temperature. It actually feels warm to the touch over the swollen joint, and pain and stiffness that usually gets worse with activity. We do tend to see, again, a symmetrical onset in the smaller joints of the hands and feet, which with osteoarthritis, we tend to hit some of the weight-bearing joints first. So this, again, is not typical of osteoarthritis to see the hands and the feet being affected. The joints can become deformed and ankylose, fuse, or sublux dislocate. Pain will lead to some muscle atrophy in the surrounding musculature. And again, like I said, there can be some non-specific, more systemic symptoms such as a low-grade fever, loss of appetite, malaise, fatigue, that you'll see, especially again during a flare-up. So patient management during the active flare-up, patient education a lot, again, joint protection, energy conservation, what should the patient do and what should they not do. We will try to work on some joint mobility, but again, this is going to be very gentle joint mobility. We will give them some exercises to do as well as some functional training, but again, this is going to be very gentle within their tolerance, not increasing their symptoms at all. A few things to take into advisement as far as precautions go. Steroidal medications are typically your treatment of choice for rheumatoid arthritis. The one big one now is methotrexate, which is actually not a steroid, but it is an immunosuppressor. So whether they're on steroids, which can then lead to osteoporosis and some ligamentous laxity, or they're on immunosuppressors, there's some downsides to each of those medications. But if they are taking steroidal medications, watch excessive stress to the bones and joints. We want to be very careful because of that laxity and because of the osteoporosis that can develop with the bones. Some contraindications to exercise with RA is that we never want to stretch a swollen joint. So remember, not stretching. We can do range of motion with that swollen joint, but we don't want to stretch it because we can very easily overstretch the joint, which can lead to some hypermobility down the road. Again, that can distend the capsule, can lead to laxity and possible subluxation later. So you can perform range of motion within their available range, but don't stretch during an active flare-up. Once they're in a subacute stage, so once that flare-up is starting to subside, again, we can continue with joint protection and do some activity modification just to make sure that they're still comfortable. Flexibility, you can do some stretching at this point. So if they've gotten stiff because of the flare-up, you can work on regaining that range of motion. You can work on cardiopulmonary endurance, so any type of aerobic activity, aquatic, cycling, dancing, walking, again, anything that doesn't flare up their symptoms. And again, contraindications, any vigorous stretching or manipulative techniques, especially in the cervical spine. We never, ever, ever manipulate a patient's cervical spine who has rheumatoid arthritis because of the potential for joint laxity, which can lead to some very disastrous issues if we manipulate the cervical spine. So we'll just steer clear of that with our patients who have RA. Osteoarthritis, it's a chronic degenerative disorder which affects the articular cartilage, wears it away, and we have overgrowth at the joint margin. So this is where we have those osteophytes or bone spurs that start to occur. You'll see some synovial and capsular thickening, joint effusion. So there it's going to look similar to RA. The two will present similarly. Also see activity limitations, participation restrictions. This is usually self-imposed, right? The person hurts, it hurts to get up and walk around, so they're not going to as often. Osteoarthritis is one of the leading causes of disability in the older population in the United States, so there is a significant social and financial impact. So if you look at this picture over here, you can see on this first knee that nice clear joint space between the two bones. And then when you look over at this one, you see a much more narrow space between the two bones. You can also see this osteophyte developing off to the side here. So really, this is like wearing down to almost bone on bone right here. And this is the medial compartment of the knee. You can tell because here's fibula over here. But the medial compartment of the knee does tend to wear down before the lateral side. And then obviously if you have bone spurs developing in there, that's going to be pretty uncomfortable too. So that's going to hurt, and weight bearing is going to exacerbate those symptoms. Some characteristics of osteoarthritis: we can see capsular laxity, which can also lead to hypermobility and instability of those joints. And this usually comes from either some type of injury or just overuse. Again, the weight-bearing joints are going to be the most affected with osteoarthritis, so hips, knees, spines, sometimes into the shoulder and hands as well. There may be a genetic component to this as well, so if your grandparents had osteoarthritis, you might be slightly more likely to develop osteoarthritis as well. There's some risk factors, known risk factors for osteoarthritis, and some we can control, some we cannot. But being overweight, obese, tends to wear the joints down a little bit faster. Weakness of the quads, doing any type of sports or work activities where there's repetitive impact on those weight-bearing joints, kneeling, heavy lifting, things like that are going to tend to wear down those joints a little bit faster than someone who doesn't do those things. So with osteoarthritis, again, the cartilage is going to start to thin out and eventually split to the point that you do have bone on bone. When you get to that point, you'll hear what we call crepitus, which is kind of like that grinding of the bones together. Loose bodies can also occur, and if that happens, they kind of float around in the joint space and can get caught and can be very uncomfortable as well. The subchondral bone will eventually become exposed and wear on the other bone, and again, this is very painful. The affected joints can become enlarged. If you think about it, if you've ever seen someone with pretty advanced like knee osteoarthritis, their knees do tend to look rather enlarged. In the fingers, you'll see sometimes the joints of the fingers start to become enlarged as well. These have specific names. If it is at the distal interphalangeal joint, they're called Heberden's nodes, and at the proximal interphalangeal joint, they're called Bouchard's nodes. And again, the weight-bearing joints are the ones that are going to be most commonly affected, so your hips, your knees, your spine. With the hand, this is one way you can tell the difference too, or for whatever reason, osteoarthritis tends to affect the DIP joints and the thumb. RA does not tend to affect those. RA tends to affect the proximal interphalangeal joints more so than anywhere else. So management, how do we treat patients who have osteoarthritis? So again, patient education is going to be key. Again, try to get them moving as much as they possibly can. I'll say it here now, I've said it before, I'll say it some more, but studies have shown that active exercise, aerobic exercise, walking, can do as much for arthritis pain as taking over-the-counter pain meds. So just teaching your patients that a little bit of activity is actually very important for them to do, even if it hurts. If it does hurt, maybe there's some things we can do to make it hurt less. Maybe we can give them an assistive device to help offload that joint a little bit. Maybe they can use some splints, or we can do some activity modifications. So instead of jogging, maybe we'll elliptical or we'll bike or we'll swim where there's less force put on those joints. So try to manage the pain, but still try to keep your patient active. As I mentioned, we may use assistive devices with them, canes and walkers to help offset the joint loading. Even things like a raised toilet seat will make it much easier for them to go to the bathroom, get up and down without having to get all the way down to a standard height toilet seat. Aquatic therapy can be really, really good for this patient population. We have a whole unit on aquatics later. I'm a big proponent of aquatic therapy, but especially for our arthritic population, they can oftentimes get in the water and do so much more with so much less pain than they can do out on land, like we say. So if they have access to a pool, if you can get them into water, they usually do really, really well in there. Resistance exercise is important. While we as therapists can't do a lot to reverse the arthritic changes that are happening, we can give them strengthening exercises and strengthen the muscles around the joint that's deteriorating to try to give that joint a little bit more support. So it can actually help them in the long run, give them more stability and less pain by doing some strengthening exercises. Maintaining whatever range of motion we can through stretches and joint mobilizations, working on balance activities to make sure that they're not going to end up falling, especially if they're not using an assistive device, and again, some aerobic conditioning just to keep that overall cardiovascular health up as well, because they are going to tend to want to be a little more sedentary because of the pain. All right, so moving on to fibromyalgia. This is a chronic condition that's characterized by widespread pain. This is a soft tissue disorder. This typically does not affect bone. It covers half the body and the axial skeleton. So a lot of times we are looking for presence of trigger points or tender points with at least a diagnostic criteria of at least 11 of 18 present, meaning they have pain at those points. Some symptoms of fibromyalgia include non-restorative sleep, meaning they sleep a full 8-9 hours a night and still don't wake up feeling refreshed. They're stiff in the morning, fatigued, and decreased tolerance to exercise. There's currently about 5 million people affected by fibromyalgia. Women are a little bit more affected than men, and the chance of developing fibromyalgia increases as you age. So some of the characteristics, usually we see the symptoms appear in middle adulthood. They may develop after a trauma, like a car accident or a viral infection, any type of trauma. We can see this start to develop. And again, this is usually affecting the muscles and the soft tissues. So muscular pain, especially around like the axial skeleton. So the head, neck, chest, low back, kind of through the trunk, basically. Patients who have fibromyalgia do have a higher incidence of tendinitis, headaches, irritable bowel syndrome, restless leg syndrome, TMJ disorders, mitral valve prolapse, and then anxiety, depression, and memory problems as well. People with fibromyalgia do also tend to have periods of flare-ups and sort of remissions, or times when the disease is more active or painful than others. They do sort of attribute some of this to potential environmental stresses, so things like weather changes, barometric changes. I actually used to work with a PTA, and it wasn't fibromyalgia, but she would get migraines with barometric changes. So every time a storm was about to come in and the barometric pressure dropped, that would trigger a headache. So I have actually seen that kind of thing have an effect on patients. But cold, dampness, rain, fluorescent lights, all of those can potentially trigger some of the symptoms of fibromyalgia. And then really any type of stress. So whether it's a physical stress or emotional stress, stress does tend to increase the symptoms of fibromyalgia. So one of the treatments, which we are getting to, can be to try to minimize or learn ways to deal with those stresses. So as far as treatment of fibromyalgia goes, research again supports the use of exercise, especially aerobic exercise, which can be very difficult to talk your patient into, especially when they're hurting. So any type of movement, any type of activity that we can get them to do, even if it's just a little, is going to be beneficial for them. With that, aquatic therapy may also be beneficial. It might just be a way for them to do some exercises in a less painful environment. The patient can take some prescription or over-the-counter meds just to treat some of the symptoms that are present, to take care of some of the soreness. Pacing activities, again, just to try to keep things at a continual pace, try to regulate their symptoms. They can try some cognitive behavioral therapy, trying to avoid their stress factors or find ways to manage their stress, maybe different ways to try to manage stress. Decreasing alcohol and caffeine, and then they are looking into possible diet modifications as well that may help to diminish some of the symptoms. All right, somewhat closely related is myofascial pain syndrome or chronic regional pain syndrome. Again, we are looking for the presence of trigger points for this or a specific referred pattern of pain. So again, your trigger point is going to be a hyper-irritable area within a tight muscle, and they will experience pain with stretching. They'll have decreased range of motion, decreased strength. So usually pain, stiffness, weakness. Some causes of these trigger points can be chronic overloading of the muscle or even an acute overload, usually due to some sort of trauma, poorly conditioned muscles, postural stresses, and poor body mechanics. Oftentimes this is more of an overuse or gradual development over time. Again, it can be really linked to a trauma as well. So management, again, if we can figure out if there is something overloading these muscles, if this is due to a postural disorder or something like that, we can try to alleviate the symptoms by addressing those issues. We can try to work on the trigger points with some of the techniques that you guys learned back in procedures when you learned about massage, doing some trigger point release, spray and stretch, modalities, ultrasound, e-stim, dry needling or injection are one of the newer ways that they're starting to look at dealing with this. And then once you can get the person feeling a little bit better, we want to make sure that we're strengthening the muscles to maintain good posture and not to overload the same muscles that are getting overloaded. Osteoporosis is another bone disorder. This is a decreased mineral content and then a weakening of bone, which can lead to fractures, especially of the spine, hip, and wrist. Those are the common fracture areas. You can see in this picture here, this spine, this is that characteristic sort of hunched over posture, so the patient's head would be up here. And the reason we see that sort of hump in the back with people who have advanced osteoporosis is that the vertebrae actually start to fracture and collapse. So that can be very painful as well. We tend to see fractures of the hip and wrist because if the patient would fall, they either usually put their hand out to stop them and fracture their wrist that way, or if they don't and they land on their hip, then their hip can fracture because the bone is weaker than it should be. There's currently about 10 million Americans with osteoporosis, and 80% of them are women. So this absolutely affects women more than men. A diagnosis of osteoporosis is done by a bone mineral density scan with normal values ranging from -1 or higher, and then you can see it goes into osteopenia, which is a milder form of osteoporosis, and then full-blown osteoporosis is -2.5 or less on the bone mineral density scale. Risk factors for osteoporosis are being a woman, postmenopausal, Caucasian or Asian descent, family history of osteoporosis, there is a genetic link for this, low body weight, little or no physical activity, and then a diet that's low in calcium, vitamin D, smoking also increases your chances of developing osteoporosis. Some secondary diagnoses are some other medical diagnoses like GI disorders, hyperthyroidism, chronic renal failure, and alcoholism, as well as the use of certain medications like glucocorticoids. So those are used to treat some of the other disorders, and then a side effect is potential development of osteoporosis. So the National Osteoporosis Foundation recommends the following things in order to decrease your risk of developing osteoporosis. Make sure that you're getting plenty of calcium and vitamin D. So most women, if they're not, can take supplements or do make sure you're somehow getting enough of those nutrients, because those are going to be most important for your bone health. Do weight-bearing exercises, and this is a big one. So in therapy, if we're treating someone with osteoporosis, we do want to make sure that we are giving them weight-bearing exercises, walking, on the treadmill, even the elliptical, which maybe takes a little bit of the stress off. But we want to avoid actually things like aquatic therapy, because for some populations, like those with osteoarthritis, that can feel really good, and we want to take the weight off of those joints for them to make them feel better. With osteoporosis, we actually need them to bear weight through the joints. Wolff's Law, again, by bearing weight through those joints, that'll help to remodel those bones and strengthen those bones. Promote a healthy lifestyle with little to no alcohol consumption, no smoking, regular doctor checkups, and bone mineral density testing if necessary. So again, recommendations are going to be weight-bearing exercises like walking, jogging, climbing stairs, again, anything that will help to put some force through those joints. Non-weight-bearing exercises are okay, like cycling and aquatics, but we need to make sure that's not the only way that the patient is exercising, because that is not going to be as beneficial for them. Aerobic activity at least 5 days a week would be ideal, and resistance training. This is another big thing, and we have a whole lecture later on in the term about exercising for geriatric patients, but we tend to shy away from resistance exercises for the elderly, or we don't give them as much resistance as they can probably handle. So don't be afraid to kind of load them up a little bit, again, within the patient's tolerance. We would like our patients with osteoporosis to do about 2 to 3 days a week of resistance training, 8 to 10 exercises that target some of the major muscle groups, so just a total body sort of resistance program, and the ability to do somewhere in the ballpark of 8 to 12 reps to fatigue. Things to be cautious of with our patients with osteoporosis is that we want to avoid stressing into spinal flexion. If we flex their spine, that's going to put pressure on those vertebral bodies that are already potentially collapsing. So things like crunches or anything where that machine at the gym where they crunch forward, they shouldn't do that one. We also don't want to flex and rotate at the same time, again, because of the force that's going to put on the vertebral bodies that are already weak. It's totally okay to do resistance exercise, but again, increase that resistance gradually. Don't do too much too quickly, because we could potentially injure them that way. All right, to talk about some fractures. Fractures are going to be identified by the site of the fracture. So whether it's in the long shaft of the bone, at the epiphyseal plates, to the extent at which it's fractured. Is it a complete fracture or an incomplete fracture? If it's transverse, oblique, or spiral. If the bones are displaced or not. And you can see in this picture, E, right here, these would be displaced. This would be non-displaced. This one would be a displaced fracture. And then the relationship to the environment, whether it's open or closed. An open fracture is a bone that is fractured and then comes out through the skin. Any type of fracture, no matter what it is going to require urgent medical attention, not PT. Risk factors for a fracture are going to usually sudden impact. These are usually some sort of macro trauma, some direct trauma to a bone. Osteoporosis increases the incidence of fractures, again, because their bones are weaker, so even something minor can potentially lead to a fracture. A history of falls, low BMI, low physical activity levels, and increased age, and that makes sense. Signs and symptoms of a fracture are going to be some of those risk factors, right? Someone had sudden impact or had some sort of trauma to the bone. Localized pain that hurts when they move it. Muscle guarding, again, the body's going to try to protect that area. Decreased function, swelling, deformity, abnormal movement. Bones, when they fracture, will oftentimes bleed a little bit, so there's oftentimes bruising around the area as well, and very tender to touch. As far as cortical bone healing, again, we're going to have the inflammatory phase. So again, you do often see bleeding that occurs. So you may see bruising in the surrounding area. That will eventually clot off and then get into the reparative phase, where the hematoma is going to form and a callus forms around the fracture site. A callus, if you don't know, is visible on x-ray. When you look at an x-ray of a healing bone, a callus looks like a white sort of cloud around the open fracture. And that is a good sign. We want that to happen because that's a sign that the bone is starting to heal and grow together. In the remodeling phase, that callus is actually going to harden. That's considered to be clinical union when the ends of the bone are now reconnected together. So that's usually when immobilization is no longer necessary. So they'll take off the cast. You'll start to be able to do more movement at the joint. And then radiologic union happens when the callus is actually replaced with lamellar bone. So that's going to take a little bit longer. You might see some rigid internal fixation. That is going to be when they go in and they do surgery to put rods or pins or screws or something in the bone to kind of hold it together. Healing time for fractures, kids heal relatively quickly. So a child can heal from a fracture in 4 to 6 weeks. If I haven't told you the story before, my oldest son, Lucas, was on a sliding board when he was just shy of 1 year old, riding down on the lap of his cousin, and he ended up with a spiral fracture of his tibia and had to be in a full leg cast. Because he was so young, he only had to wear his cast for 3 weeks. So he actually healed pretty quickly. Adolescents will heal in about 6 to 8 weeks, and adults can take as long as 10 to 18 weeks, depending again on the severity of those fractures. Other bones, cancellous bones, these are our flatter bones, right, that are typically injured by a crush type injury. Those do usually heal a little bit faster than the long bones. If the surfaces would be pulled apart, then it might take a little bit longer then, but they can also be casted and immobilized to allow them to heal. Epiphyseal plate, we do need to be careful with kids that if they fracture around the growth plates, that can disrupt their long-term growth. So it depends on the type of injury, the age of the child, the blood supply to the area, and whether it's open or closed. So the doctor will take a look at that and decide the best course of action for that healing bone. So during immobilization, because most fractures are going to be immobilized, we will see some connective tissue weakening. The articular cartilage will start to degenerate because, again, they're not moving, they can't move, so that synovial fluid is getting more stagnant and not feeding the articular cartilage. Muscle atrophy, if you ever had a broken bone and were casted, you can attest to the fact that when that cast comes off, those muscles are absolutely atrophied. Decrease in circulation, and there could be some soft tissue injury as well, depending again on the type of fracture that there was. Again, as much motion as we can do, especially in the surrounding areas, the better. So anything that's not immobilized by the cast, get it moving as much as possible. And then once the cast is removed, then again, there is union of those bones, and it's usually safe to start moving them. So we can do some joint mobs, PNF stretching, functional activities, scar tissue mobilization, and then begin some muscle strengthening. Typically, our sequence is try to get back some range of motion first, so try to address that, and then begin some gentle strengthening as well. All right, thanks guys.